of everyone's time, I would like to go ahead and begin this meeting. We are going to talk today about predictive analytics. Our speaker today is Dr. Joni Padden. She began her nursing career as a trauma ICU nurse in 1992. Oh my God, oh no, 1992. Today, Dr. Padden is board certified as a clinical nurse specialist in adult health and informatics nursing and is CPHIMS certified. Dr. Padden is, okay, and there's lots of initials here. Dr. Padden is a member of the DFW Hospital Council Sepsis Strike Force Task Force team. She's past president of the DFW ANA chapter and a member of the HIMSS Nursing Informatics Committee. Pronunciation unknown. In her current role as the Chief Nursing Informatics Officer at Texas Health Resources, Dr. Padden works with frontline staff and clinical leadership to develop best practice to support superlative patient care and outcomes at THR. So with that being said, Dr. Padden, the floor is yours.
Thank you so much for that very lovely introduction. Appreciate that. See if I can actually get Teams to share my presentation correctly. So let's keep our fingers crossed, shall we? And let's see. So are you seeing my presentation slide or are you seeing the whole PowerPoint slide?
We are seeing the whole thing. I think you just need to do a slide. There you go, I think.
Did that work?
Nope.
Well, you just gotta love it when that occurs, right? And so we do that. And we're going to do this the old-fashioned way. How's that?
Now we are down to one slide. Thank you.
Make that as big as I can without absolutely screwing it up. All right, so thank you for the lovely introduction. Appreciate that. Yes, I have lots and lots of initials behind my name. I'm a proud member of the CPHIMS Nursing Informatics Committee. It's a national committee that works on nursing informatics issues, and the DFW ANIA Association, which is near and dear to my heart, as well as the National ANIA Association. So informatics is my life. I have enjoyed it quite a bit for the past several years after my wonderful time in the trauma ICU and trauma administration things. They're still my peeps. I still think of myself as an ICU nurse, even though I know I am informatics now. What I am privileged to talk to you all about today is the Sepsis Predictive Analytics. And so for Sepsis Predictive Analytics, and I'm going to go into this, this is one of the biggest, hottest, most wonderful things going on within informatics right now is sepsis predictive analytics and predictive analytics overall. Let me move this away and go to this. All right, so just a couple of housekeeping items. I have no conflicts of interest with the material that is being presented. I have nothing to disclose. And I am not being paid for this presentation, even though it is lots of fun. I would like to thank the sponsors for this presentation is for the DFW Hospital Council Foundation and for JPS Health Network. The Hospital Foundation, they are who really do this entire thing with the Sepsis Strike Force. They pulled us all together several years ago. This has been an amazing team to work on, and then them producing this education is wonderful. A huge shout out to JPS. The JPS has been very generous in providing CEs for events, not only this event, but other events that I've been working on, and that they continue to do that in this environment where CEs are very difficult to obtain and to do. Thank you very much for the support of that. I personally am grateful, and I know that the members of many of the organizations I belong to are very grateful. So just a smidge about Texas Health Resources for those that may not know. So we are a very large North Texas organization. We have 25 hospitals. 19 of those are on our same instance of Epic. Epic is our electronic health record vendor. We have over 22 outpatient facilities and a whole bunch of private practice folks. So we pretty much cover the gambit. And then the slide of pride, we do have magnet organized organizations. In fact, our Dallas hospital was just recently recertified for the 4th time as a magnet facility. So we have some things to which to brag about for that, which is always nice. Then for the informatics geeks on the webinar, said we are stage 7. We have won the HIMSS Davies Award in the past. One of our pieces for the Davies Award was our predictive analytics program, which we'll be showing here. And then we also had our CIO as the CIO of the Year Award for HIMSS and CHIME, which in the informatics world is kind of the Nobel Prize. So it's always rather fun. Our learning objectives for today is we want to review how predictive analytics are related to the sepsis work. We want to see how predictive analytics can improve the identification of sepsis. Early identification is key in helping our patients to survive and have good outcomes. And we want to demonstrate how sepsis and the deterioration predictive analytics can really improve the outcomes for our patients. So those are the things we're going to be discussing for our webinar today. And just a quick definition for those of you that kind of know what predictive analytics are. Predictive analytics, and this comes from the SAS Insights, so this is their definition, but it's a good one. It's really the use of data and statistical algorithms. It's all of the cool things. It takes everything that is being put into the record, all of the data that is available. It takes that and then it crunches those numbers to identify what is going to be happening in the future. And there's some really good things outside of healthcare that might help you with this. So how many of you all have ever looked at your credit score? If you've ever looked at a credit score, you've looked at predictive analytics. So what credit scores do is they take a lot of the information that is well known about you throughout the electronic environment of the world, such as your credit history, any kind of applications you've made, the different kinds of payments you've made. All of those things get crunched through an algorithm to give your credit score. And this helps the banking community to identify the risk of, whether they should be loaning you money or letting you sign up for the car or whatever those things are. So that's one of the most common things that people think about when they think about predictive analytics is a credit score. In healthcare, however, we have a lot of different applications for predictive analytics. And the more that the healthcare community learns about predictive analytics, the more things they want to have predictive analytics applied to. So one of the most common and one of the very first predictive analytic programs we saw was the modified early warning score. And I'm going to go into some of the history behind that here in a moment. Some of the other ones that you might be very familiar with. So any kind of a disease progression score, Parkinson's disease scoring, heart disease scoring, the Apache scores are predictive analytic scores. They predict how likely you are to die. There are several of those scores that are well known to us, and then we might not think of them as predictive analytic scores, but that's actually really what they are. And then one of the other things that we do within healthcare is we use these kinds of predictive analytic scores to help build our clinical decision support tools. And when I say that, a lot of people will automatically think, oh, best practice alert. And that's not really what I'm referring to. A best practice alert is a version of a clinical decision support tool, but it is not really what we're talking about. In this instance, the clinical decision support tools that we're talking about are things that allow the clinicians to see what's going on, to get a better view of the data, have it more compressed and easier for them to understand and see in a small space, and then the ability to act on it. So those kinds of things that we give them, for this tool, we're going to give you the right orders to place. We're going to give you the right assessments to do. We're going to pull up the different kinds of radiology reports you need to see so that you're not having to go and do that manually, that we can do that for you within the system based on what a score is. And then one of the other things about any predictive analytic tool, just like with the reference back to the credit rating score, is you have to teach whatever your predictive analytic model is to really look at that data set to make its decision. So you, in essence, you have to teach it to think on, okay, here's what it's seeing and here's what it needs to do to give you the score. So the models have to be taught on what's being done. And if they're not taught correctly and they're not mapped correctly, then they don't give you the correct answer. So it's not just something super simple. There is a lot of work that goes in behind the scenes to make sure that these are accurate, valid, and are giving you the correct data going forward. And if the organizations haven't done that kind of work, then you don't get the kind of score and impact that you would see when it has been done well. So I'm going to take you through the predictive analytic journey that we've had at THR as it relates to sepsis, and then show you a couple of the other things that we've been doing in our predictive analytics space. So our journey really at THR, we knew a long time ago that we wanted to begin to do more predictive analytics. And we started working on that as an organization even before we went up on Epic. We were doing a lot of that on paper. And as we began to go up with Epic, then we began to explore the different ways that we could put those in. The thing about sepsis identification is that we all know that to improve the outcomes for sepsis, you need to identify the patient as early as possible and then intervene effectively to keep sepsis from really getting worse and impacting the outcome of the patient. So the earlier we know about them, the better off we are. And we have done all kinds of things within our record that I'm going to go through to try to get us to that point of that early identification. And part of this, like I said, began long before we went up and then has progressed through. In February of 2019 is when we put in the EPIC predictive analytic sepsis likelihood score. And I'm going to go through some of that timeline in piece. And that was really the game changer for us, and that it allowed us to really begin to see in real time things that were going on. Almost immediately after implementing it, we began to see some good saves and some early rescue. So we've seen some excellent benefit out of this. And the more that we refine it and the more that we expand its scope and use within the organization, the better our outcomes and things have been. So that's what the slides are going to take us through, the kind of the journey of where we started in predictive analytics for sepsis, and then where we are today, and then end with where we are now beginning to take it as we go forward into the future. All right, so way back in 2012, we were trying to come up with a way in which to identify sepsis early. And so we already had in place our modified early warning score, and we began to couple that with the SIRS score, so that when you saw those two scores going up, that was the trigger for the clinician to take a closer look. And we tried to put these in our EPIC system in the places that our users were most likely to look. However, adding the things in, this was all very user dependent, meaning we didn't do any of this automatically. None of it was mandated by policy. It was just there for them to use if they chose. We were very intentional at that point with not putting this kind of thing in policy because we did not want to mandate something that they might not find useful for their patient. We've come a long way since then. But just in the early days with this, it really was rather rudimentary, just trying to give them the tools and access to it and then seeing where that took them. Well, as we all learned, that didn't take them nearly as far as we wanted it to take them. So we also began to show this kind of information in our ED environment. As we all know with sepsis, that 95% of your patients are going to come in through the ED. That our sepsis patients, that's where predominantly they come from. We do see some within the inpatient after they've been admitted, but the lowest hanging fruit is getting those as they come into the ED. So we began to look at that as an organization, putting the SIRS in the different tools that they were using. But we found that we had several of our hospitals that they had different guidelines on what to do when they saw a high SIRS score. And there was not really any standardization across the system of what they were doing. And in fact, some of them would see the SIRS score and then they would begin a paper process of additional screening, and then they would have a paper process on what they were supposed to be doing according to sepsis. So there was wide variation across the organization as to what we were doing as it related to sepsis care. Even though we were giving them some of the tools standardized within the record, their response to it was anything but standardized. As mentioned, several of them had paper screening tools. So they had these tools, several of them had, everybody had a different paper screening tool. Imagine that. We were able to, in 2013, actually get to the point where they all had the same paper tool. So step forward there long ago. And we had 2 of our hospitals were in the sepsis DSRIP studies and were part of the DSRIP hospitals with what they had to report according to their DSRIP. So it was very difficult at that point to standardize because of all of the regulatory pieces that those 2 hospitals were having to do differently to meet their DSRIP standards. So again, a lot of wide variation in what we were doing as a system and then the tools that we could provide for that. They did come to a consensus, and we did put into our ED build that they would all have the same sepsis screen. So we put in a smart form that they could answer some of the questions. We were really proud because some of the questions would be answered automatically for them at that point. And then there were others that they had to answer, and then they had the ability to rescreen. And we put this in, and we were very proud of the build with it, and put it in for them. But what we found was that they really weren't using it as much as we wanted them to use it. It was out there, but it was varied in how much they were adopting it. They didn't find the alerts and things that were tied to it to be all that effective. And so we continued to work on it. So we never give up. And in 2014, we updated it. We gave them a much better smart form because this is when the CMS Step 1 core measures came out. We were really trying to drive adoption of that with these. We introduced new BPAs that were related to it. And again, we did all of this great work, and it really wasn't being adopted at the hospitals because it did not really flow with their workflows. There were other things that, they still had some variation across the organization on how they were responding to it. There were a lot of factors, but we did not see the adoption with this that we really wanted to. And about that same time, in 2015, Texas Health Resources went to a new program that we call the Reliable Care Blueprinting, or RCB module. And RCB is that you take a care process and you really look at it very closely. It's very data-driven and evidence-based driven, and you try to figure out what outcomes you're really trying to meet, and then you engineer a process surrounding the entire thing, from everything from assessment through supply chain, everything that would be needed in which to address it. And in 2015, one of the very first RCB modules that we did was related to sepsis. And in doing that, we identified that, yes, we did have a problem. We had different workflows, the emergency departments versus the inpatient departments. Everybody was doing something a little bit different. We had the iterations where we did the screening tools. Then as we went forward with our RCB module, we did the first design in 2015. Then we went back in 2017, where we came up with our very own homegrown predictive analytic tool to help identify. That went really well. We were using that to great effect. And then Epic began to come out with their different predictive analytic tools, the sepsis likelihood score being one of their first tools to come out. And then we began to adopt it. And now that we're into our next iteration of our sepsis design, we're now beginning to take the sepsis likelihood score and apply it to our inpatient population as well as to our ED population. So the iterative learning, the ways that we continue to improve on this are going forward. Even today, we are in pilot today, which I'll get to a little bit later in the presentation. Like I said, we just refuse to give up. We are applying everything that we know to try to identify sepsis early and get our clinicians what they need, not only from an identification standpoint, from the predictive analytics, but also what now you need to do with order sets, things that are driven that really do take them down the pathway, and to make it as easy as possible for them to do the right thing as quickly as possible as it relates to sepsis. And with each iteration of what we've done, we have seen improvement, but it was never as significant as what we wanted until really we began to use the predictive analytic tools that were generated by Epic. Once we started to do that and really build according to that is where we've seen our greatest amount of movement. So a little bit more about the RCB design process, because that will be important as we go through some of the next slides. At THR, and we do have it trademarked, that it is a very set process that we pull together design teams. The design teams have members from all stakeholders. So for sepsis, it's nursing and pharmacy and physicians and the lab, and so everyone that has a stake in it has a stake in it. We have the coders, we have our abstractors, everyone is represented on the team. And we review very specific things about it, but we're looking for the things to achieve the outcomes based on these aims. Then this team gets together and we engineer the process. We look at everything from staffing, skill mix. We want everybody to be working at the top of their license, and we want to support them. And if that means that supply chain needs to get a new chlorhexidine wipe, because that seems to be the thing that's reducing our CLABSIs, then it goes to supply chain. We include the environmental services if we need to. Anybody that needs to improve on the process is included within it. And it's not just, okay, in my world, everything is documentation and everything's in the EHR, but really RCB is much bigger than that. And it includes the things that we hardwire within our electronic documentation, but it also includes hardwiring in other things, signs for the units, badge buddies, anything that we feel is needed to hardwire the process. RCB helps to design and deploy that. And then deployment, making sure that we have support at the entities, that there are key focused people that is their job, is to make sure that these things are deployed well, and supported once they're out there. And then you can never forget this one, you have to measure and report. And that's one of the reasons that we continue to have our iterative designs, as we have key measures, both process measures and then outcome measures for every single one of our RCB modules. And then if we're not meeting our targets, then we go back and look at what we need to go back and design and or redesign to help to meet that. So we're never quite done with the cycle. We get as good as we can get. And then if we ever slip, we want to go back and figure out why and address it using this same process. So our initial launch for our sepsis build, like I said, we started it in 2015 to get the design and build, and then we were able to really launch it. And in that launch for sepsis, we included our screening for inpatient. We used 3 things in which to trigger our response to help the staff identify early. And that was the Muse score, the SIRS score, and then the shock index score. And if all 3 of those met a threshold, then that would trigger an alert to the staff, and that would include the nursing and the physician staff, to make sure that they knew that the patient was at risk, to do the further assessments, to start applying the order sets, to call the RRT if necessary, all of the steps that would need to occur. And in the ED, when we started this out, we actually kept them at a manual sepsis screen because that's what they asked to do. And they did not think that the trifecta, as we like to refer to it, was going to work for them. However, we did have order sets available for them. We did trigger different BPAs within the Epic environment. We made sure that we had a sepsis navigator. That's something that groups all of the information together so you can find it in one spot and act on it. We had very defined metrics that we were using for it. We had a lot of leadership support. That is key to anything that you do and succeed with, is leadership was behind us. And this was something as an organization we wanted to do. It wasn't just this hospital with disrupt or that hospital because they had a bad case and they wanted to address it. This was a system-wide organizational focus for us to improve on our sepsis care. Then in 2017, we actually began working on this in 2016 because we did not like the manual tool answer for the EDs. We came up with a THR created and built predictive analytic tool that we called Think Sepsis. And it was a very sophisticated tool that looked at a lot of different data points that were already documented within the EHR, so that the nurse and the physician didn't have to go document anything extra to make it fire, the system was looking to see, was the patient here for an infection? Did they have a line? Did they have some kind of a surgery or a wound? There were several of the things, what were their vital signs? Was their temperature up? What were the indications the patient might be at risk for an infection? And if they're at risk for an infection, then you need to be thinking sepsis. And you need to be, making sure that you're looking for it, one, and two, treating it if you even think that it's there. So this required us to go back to our RCB process. We reworked all of our BPAs. We reworked all of our triggers and documentation in the ED to follow the Think Sepsis guidelines. And it actually worked really rather well. So as that continued to roll out, it gave them, they wanted to know, okay, why did this BPA go off? Why are you showing me this information? My patient looks fine. Why are you giving me this alert? Well, we found when we showed them what it was that was causing it to fire, that helped their clinical judgment. Again, the information in the EHR is massive. There is no way that any one person can go and glean everything out of the EHR and make a decision for a patient quickly. So what predictive analytics does, and what we did with the Think Sepsis, is we condensed that down. We pulled it in for them to show, okay, here's why we think they're at risk for an infection and possibly sepsis. And here are some things that you really need to be taking note of in your assessment. And having that all pulled together for the clinicians really did help them. We had a better idea of what they needed to see in reports as it were, pertained to their risk of infection. And while we were doing this, we were still using the Muse, SARS, and Shock Index because, like I said, the Think Sepsis, as good as it was for the ED, was not working as well for inpatient as we wanted it to. We thought really hard about doing it, but every time we did the analysis on it, it was one of those, okay, it's still just as good as what we already have in for inpatient. There really wasn't a reason for us to change it at that point, but it was working great for the ER, and we continued down that path. So I've talked a lot about the timeline. And so this is a little bit better graphic for where we are in our sepsis predictive analytics timeline. So when we started back in 2012, we had Muse. We rapidly added SIRS to it. Then we began to do our kind of manual screens, and that was great. In 2015, and it's right before we do the shock index, and this is the same time frame that we were beginning to do our RCB work, is THR partnered with IBM and Watson to try to teach Watson how to identify sepsis. And the biggest lesson out of that is it's very difficult to train a machine how to identify sepsis. Something that the clinician can do quite, now I'm not going to go easily, but definitely faster by looking at the different pieces. It was much easier for the clinician to take the same information and arrive at a sepsis, yes, it's sepsis, no, it's not sepsis, then we could get the machine learning and Watson to do. But we had extensive work with IBM and Watson, and that taught us a lot too about our different tools, which is kind of how we came to our Think Sepsis tool, because it wasn't as sophisticated, but it worked for what we needed it to. We began to employ our shock index analytics. I'm trying to remember what SOFA stands for. I had it at the top of my head, but it's the organ failure assessment. And so we employed that within the record. So now we could begin to show the organ failure assessment to the clinicians. In 2018, that's when the sepsis likelihood, we began to use that in the ED. And a piece on that, we actually installed sepsis likelihood back in 2017, but we did a lot of analysis with it before we released it out into our production environment. We wanted to make sure that it was valid and that we were really able to identify patients that were deteriorating because of sepsis or that were at a risk for having sepsis before we released that out. So there's a lot of back work that has to go on with that kind of release that you're wanting clinicians to make a clinical decision for. It has to be validated, has to, and that is not a small lift. In 2019, we began to use the workload acuity tool from Epic, and that actually began to inform us about sepsis as well. Like I said, we're taking several of these different pieces and seeing how that can help us in our predictive analytic world to make those kind of decisions for the patient. And we were beginning to see, as the patient's workload acuity went up, meaning the more meds that we were giving, the more assessments that were having to be done, all of the different things that feed into workload acuity, they would pretty much stair step up. As the sepsis likelihood went up, the workload acuity went up, and they just kept pairing back and forth. So we're continuing to look to see what the tie is between those, and if we have other things that we might be able to learn from it. In 2020, and this should in 2020 with COVID-19, the MSOFA, the modified, what is the S? It's just leaving me. The modified SOFA score, it came into play with the COVID patients because that was a good way for us to be able to triage for resources. Thankfully, thank you, dear God, we never had to do that here in Texas as much as they did in other parts of the country. But MSOFA really did help us think about sepsis in a different way, as well as COVID. As we had begun to retire the sepsis likelihood, we then transitioned our old Think Sepsis model. We retooled it and we used it to now Think COVID. So that early in 2020, when we were all still trying to figure out how to identify a COVID patient, we had predictive analytics in our system to help us identify and think, okay, this patient might have COVID. You need to have extra eyes on them, make sure they're in the correct isolation. We need to be doing the testing on these patients, that kind of thing. And as we all know, our COVID patients could become septic just like any other infection, and it tied back into our sepsis work. Here in 2021, we have now begun to roll out the EPIC Patient Deterioration Index. The deterioration index is much like the Muse. So you see, we started here with the Muse, and now we're finally beginning in current day to come back and look at that again. So the patient deterioration index does a lot better job than the Muse score does. At least that's what we're finding in our research and our comparisons. And we're looking at beginning to roll that out as we look at ways as maybe Muse is now a more antiquated tool. We might have a more powerful tool we can use. And I'll go through some of that. And again, we're currently right now today in a pilot to begin to use that sepsis likelihood score as our inpatient trigger for sepsis likelihood, as well as we use it within the ED to see if the patient is at risk for sepsis. So in the sepsis likelihood model, and if there are any data geeks out there, this is the slide that you all like a whole lot. My teammate, Tana Nelson, she's really the data nerd behind all of our sepsis likelihood stuff. She and I work well. I do the operational side. Here's what we do at the bedside with it. And she does all of the data crunch and validation of it. And when you look at the sepsis likelihood model and you compare it to the other tools, it's this little slide right here that makes everybody so very, very, very happy, is that it is incredibly accurate at a very early stage in that positive rate that lets you know that this is really working as intended. In fact, it's working better as intended, because that straight line is good, but when you have your score having this much room under the curve from a data analysis piece, that's phenomenal. And then if you want more explanation on that slide, we need to have Tana come and do a presentation on how to read these slides, because I'd be lying through my teeth if I said I was good at it. But again, on that validation, so I cannot stress strongly enough that with any tool that you put in, you need to validate it within your environment. And we did exactly that. So we had a great score in Think Sepsis, and we had validated it within our system and against our patient population. And when EPIC came out with their sepsis likelihood model, we really did a lot of validation between the two to see, were they as specific, was it as sensitive? And where we had gotten into a problem with Think Sepsis is that it was incredibly sensitive, meaning it cast a really broad net, and that we were identifying people that, potential for sepsis, yes, not really very much. But the EPIC model, while it wasn't as sensitive, it was a lot more specific, meaning it was much better at identifying the patients that really have sepsis. So when we did this kind of analysis and really comparing that sensitivity and specificity, it was very clear that, especially in our ED population, which is where we were using Think Sepsis, that the EPIC sepsis likelihood score was the better way to go. It made more clinical sense. So we implemented it. And in 2018, like I said, we did extensive testing. We had it available to our physician champions. We had it available to some select ED nursing champions that used it. And then when we were finally very confident, we released it into the wild, as I like to say, in February of 2019. Immediately, we saw great adoption with it. It was rapid, it was broad. The inpatient could see it. It just didn't fire any alerts on the inpatient. But even on inpatient, we saw a huge adoption and that they were going back and referring to it. And I cannot tell you how many times we were asked to please change all of our inpatient stuff over to the sepsis likelihood score. And we're finally in the process of doing it. Like I said, that takes a little bit more work than it did with what we did with this. We had almost immediately some excellent stories of good saves, where we had one where one of our wonderful sepsis coordinators who knew about the score was looking at it and saw it change on a patient. And so then she proactively called the nurse and said, I just noticed that this change. Can you tell me something about the patient? Well, the patient was indeed beginning to go into distress. They were able to intervene and have a very good outcome for that patient. And that was within the first couple of days of this going live. So we had some really good stories along that line. And then I said, as we got this out, saw that it was really working, we changed all of the build in the ED to trigger off of this. And that's where we really began to see some improvements in our outcomes. And then because Epic was doing this with us, Epic is an excellent partner. They have worked side by side with us in this because we are early adopters. And we wanted, every feedback that we were getting, everything that we were learning, they were right there with us as we were doing it. And we kept telling them, okay, we don't like this about the functionality, or can you make it do that? Or can it change color? Something as simple as changing the color is very helpful. So Epic worked along with us, and we were able to change the colors of the alerts. We were able to change the things that, the graphs, so that the graph showed a little bit better. Had a little bit better way to read how the score was impacting, and that just continues to improve to this day. Within the Epic environment, and I don't mean to be so vendor-centric, I know that other organizations and that other vendors have something very similar to this, and that they work in similar ways, that they have ways to show that, your predictive analytic tool, what it is that's going on. It has triggers that are color-based or that are number-based or both. The ability to see trends in graphs. As clinicians, we all know that one single data point is not nearly as useful as being able to see a trend. And with this particular scoring, it shows you an excellent trend. In fact, even the trending score will show you the green and the red, which our clinicians found to be incredibly valuable when it came to looking at the sepsis scores. So working with our partner in Epic, and then working with our clinicians in frontline, and then those of us in IT, both the data geeks like Tana and myself on the operational side, we really began to put all of these pieces together for this predictive analytics score so that it can begin to make an impact on patient care, which is why we do all of this in the first place. So current state, we have a pilot underway right now. We have three of our facilities that are using this, and we have converted over all of the alerts on our inpatient side to now trigger off of the sepsis likelihood score and not triggering off of the Muse, SIRS, and shock index like it has before. We've had some really excellent feedback from our pilot on this. We've managed to tweak some of the alerts that they're seeing and where that is leading them so that they can better act on it. We're getting close to the end of our pilot. We think that the pilot will be able to end for sepsis probably by the end of July, and then we will begin to look to roll it out to the rest of our system, hopefully in August, and take it forward from there so that we will have the sepsis likelihood driving all of our sepsis alerts, both in the emergency department and in our inpatient environments, and that we will be more standardized across our system. And with the patient deterioration index, like I said, which is much akin to the Muse score, what we're finding is, and it's meant to be a broader score, it's actually not a very good indicator for sepsis. The sepsis likelihood is much better at indicating sepsis, but what we're finding with the patient deterioration index as it couples with sepsis is that the clinicians that are using this and beginning to see the difference between the two, what one is triggering versus the other, and the actions that one takes versus the other, that is making them feel more confident when they're identifying sepsis versus identifying a different reason for deterioration. And I think that that's going to be one of our more important findings out of our pilot, is the difference in how the clinicians use the tools and the kind of clinical judgment that they come to after using these kinds of tools. And one of the other things that we've learned in informatics is that we want to, as much as possible, reduce the alert fatigue. And firing alerts all of the time for everything is a bad idea. It's just a horrible, horrible, horrible idea. Everybody, I promise you, every single team wants an alert to fire to some other team to make them do something in the record. And while that kind of sounds like, oh, yeah, that sort of makes some sense, it's a very bad idea. What you really do when you do that, one, is that they ignore the alerts. So even the really important alerts that they need to be paying attention to, because they are so fatigued with the billions of alerts, that they ignore everything. And that's the last thing that you want. So we've been very careful with managing our alerts. We've been trying to make them into what we call more passive alerts, so that they're there, they're visible, they are actionable, and any kind of an alert that we can get rid of. So if it's the, this is a billing alert, or, you need to do this so that, it can go on a report, we've eliminated all of those. If our users are seeing a large pop-up alert in their face, we make sure, one, it's actionable. So I'm giving you this alert, and here are the buttons that we want you to click to do something about it. And if you're seeing this, it's because it's life-threatening. That you're not seeing this because it's a billing problem. You're not seeing this because it's an OBS patient that's been here for too many hours. You're seeing this because if you don't act on it, they're going to die. And that really is kind of the break there, that if we're going to be popping something up in your face, it is really because the patient's going to die or you are at risk. Like with our isolation warnings, when they come up, and so if your patient has COVID and you don't have them in the right isolation, that's life-threatening to the staff. And so we want to protect them. So we're very careful with how our alerts show and what they can do with it. And we're learning in the pilot that that's really very helpful when it comes to the sepsis alerts, because just that one little thing that's changing draws their eye, and they are more likely to use it because they're not being overwhelmed with so many other ones. It's actually working as intended, which warms the cockles of my little informatics heart. And with that, that's our journey through sepsis at THR and what we're doing with predictive analytics and as it applies to sepsis. Now, we're also using predictive analytics in a lot of other things. We're doing it for falls, we're doing it for lots of our other items, but this is primarily focused on sepsis. So just, we are using them across the board for other things, but for the purpose of this discussion, it's really more about how we're leveraging this for sepsis. So I'm going to take a deep cleansing breath and see if we have any questions. See if I can open, I don't know if there are any in the chat. I haven't been keeping an eye on it.
Joni, that is a great presentation. And I know that we personally appreciate it at JPS as we start our journey where you guys have already been. Does anybody have any questions?
Sequential, thank you.
Absolutely. So Jessica wants to know, what type of sepsis screening do you do in the ED?
Excellent question. So the way that this sepsis likelihood score works is that it looks at, I think it has 80 different data points that it looks at every, I think for sepsis, it's every 15 minutes, might be every 10, but I think it's every 15. And it looks to see, is the patient meeting those criteria? And if it does, then that's the sepsis screening. So we no longer do a manual sepsis screening at all in the ED. We rely on the sepsis likelihood score to trigger. And if it does, then, it takes them down the path. Now, that said, if it doesn't trigger and my nursing judgment says, I think this patient has sepsis, then we already have in place a way for them to access those orders and order sets and to notify the physicians or whoever else they need to do that are independent of the sepsis likelihood. But we do not make them do an additional manual screening any longer, because one of the other things that we have found is that manual screenings, while they often make people feel better about themselves, they are not nearly as accurate as we would like them to be, because they are incredibly subjective, and they're also incumbent upon a very busy clinician taking the time to, one, ask all of the questions, then answer all of the questions in the EHR, and then have to document about it. So we've tried very hard to alleviate that kind of documentation burden from our clinicians. So there's not an additional manual screening that's done.
Okay. Megan would like to know, how often do you have staff clicking through, it disappeared. My question left me, clicking through something. Megan, unmute yourself and ask your question, because I don't know where.
Yes, please.
Please. So until we either get the question back or Megan back, I'm curious, are your providers in the ED, is there a grease board or someplace that you're able to see those sepsis likelihood scores?
Yes. So the sepsis likelihood score displays within our Epic environment on the track board. When it hits a certain threshold, so if it's a high likelihood score, it shows on the patient header. So it shows up in several different places, even if it hasn't been acted upon. And it's on the ED track boards, not only the ones in that the clinician is looking at within the computer, but it's also up on the Epic monitor.
Megan, I see you. Are you able to ask your question?
Am I unmuted at this point?
You are.
Okay. My question is, when you bring up these alerts, how often do you have people that get in them, read the alert, and then say, yeah, this doesn't really apply for whatever reason, and then close it out without acting? On our system, you can do a lockout. It's you do a lockout, and then all of those alerts stop for a certain number of hours, depending on what kind of alert. How have you worked with that?
We've done several different things along that line, and you're right. And that's part of what the RCB process helps us to define, is who needs to see the alert, who needs to be able to act on it, and those kinds of things. And so what we found is that for the physicians, the providers, that they have the ability to discontinue the alert for everyone to see. They've looked at the patient, they've made their determination, it's not sepsis. They're not going to do that again until, I think it's 24 hours. And if it triggers again after 24 hours, it'll kick back in. But for nursing can only snooze those for themselves. They can't snooze it for everybody. So you can delay it for yours, but the next nurse that logs in is going to continue to get it until it has really been addressed. And we have criteria for means. Okay, that means that you've drawn your lactate and you've notified document that you've notified the physician. I forget what all the things are that then turn it off. So if they've done what we wanted them to do, they don't see the alert anymore. If they haven't done what we wanted them to do, they continue to see the alerts. But it's different for the different providers, if that makes sense.
Jeannie Argo, I see your hand is up.
Yes, ma'am. Can you hear me okay?
Yes, ma'am.
I'm the sepsis coordinator educator at Wise Health System, and we are about to launch July 13th our first sepsis project alert within the system, and we use Allscripts as our vendor.
Got it.
I'm getting a little quick kickback from the floors. We've alleviated or done away with the sepsis screening in the ER because we have the alerts that'll trigger off of 3 SIRS and put an icon on the board. So, but on the floors, on the med-surg floor and in CCU, with the alert there that's going to respond or going to fire on 3 SIRS, 3 positive SIRS, they are questioning if they should continue to do the sepsis assessment. Do y'all still do a sepsis assessment every shift and upon admission?
No, we do not. Like I said,
So
in the ED, in the what we found, quite frankly, was that when you're forcing them to do an assessment on a patient that doesn't need it, it becomes meaningless for any patient that they do it on, and then they just they will do it because they know they have to, but it's not meaningful, and they tend to give rote answers. Like I said, it sounds like a good idea at the beginning, but when you see how it really, what the response to it really is, it's not a good idea after that. And we have found, we found that it's really, why are you making me do an assessment on a patient that clearly does not have sepsis? You're wasting my precious time to do this. And instead, we want to, when we have shown you, okay, this patient is at risk, this patient is, deteriorating, and it's a sepsis, they're deteriorating from sepsis, you really need to look at that patient, and here are the things you need to do, and here's when you need to do it. They're much more likely to follow through on that than if we force them to do something every day.
Right. Okay, that makes perfect sense. I'll bring that up. Thank you.
And it's hard because in informatics, the worst answer you can ever give to me is because we've always done it that way. And that's an automatic answer for me of, well, then we probably shouldn't do it that way anymore. And I know that doesn't hold universally true, that there are certain things like washing your hands you still want to do. But by and large, the way that we thought about assessments in the past is not how we need to be thinking about assessments now. We don't have the time to do it. We just don't. And we need to be much smarter and more focused in what we're doing. And that's kind of what the electronic health record is there to help us do. It has the information in it. We just have to figure out the best ways to pull it out and show it to the clinicians so they can make a good clinical decision with the right information at the right time. And that's what this does, is it gives them the information so then they can do what they know they need to do.
Susan, I see you keep lighting up. Do you have something? Susan, did you have a question? Maybe not. What you're saying, Joni, about working really smarter, not harder, is exactly what the predictive analytics are for. And I appreciate all the information. We have about 8 minutes left. Anybody have anything else they would like to ask?
Well, and if they don't, I'm gonna go back a couple of slides because there's something I wanted to pull out while y'all are formulating more questions with it. But something that's just, let me do these. So this is my contact information. If you have questions or things you come up with later, or you want to get in touch with me, please do. And then the CE information is also in this, which I think is going to be posted. So, and you should be getting an email, just a couple of housekeeping items where I go back a couple of slides that, email, if you were on this call, you're going to get an email with the link to the recording, slides, and CE evaluation within a few days. And again, thank you to JPS for all the work. I know that is hard and it is much appreciated. But one of the things I want to go back and just make sure to point out from that clinical judgment piece, and this is just a small snapshot of it. This opens up into a much bigger report that has, it's much more data rich. And this kind of goes back to what you were talking about with making folks do, go in and do a daily assessment. Well, that's, in my parlance, that's kind of mean-spirited, is that for the sepsis workflow, and it wasn't really part of this presentation, it could be its own presentation for that matter, is that in addition to this likelihood score, we take them to a report that pulls every piece of information across the record into one spot for the clinicians to be able to review. So the likelihood score is going to show, okay, here's why the likelihood score is firing, because they are, they're 65, their procalcitonin is high. It's going to pull that and show you why the score. But we all know that scores aren't the be all end all. The clinicians need the patient information to make a good clinical judgment. And the only way you do that is that you have the information at your fingertips. So this, when they click on the score, it takes them to a very robust report that pulls everything that they've told us is important to know about sepsis. It shows what antibiotics they're on now, which ones they've already had, how much fluid they've had, what their tests have been, what LDAs they've had in, what wounds they had, what procedures have they been on. And it pulls all of that together into one spot for the clinicians to be able to go and read and view and then make clinical decisions off of. So that it really is about highlighting the awareness. The score is about the awareness. But the reports and the other things that you pull together are the information the clinicians have to make a decision. And then from there, once they have that information, giving them an easy path to an order set that contains everything that they need in the order set to be able to order in one spot. So they don't have to go to the vent order set and the antibiotic order set and the whatever it is order set. They go to the one that is focused on the problem that they're trying to solve. And that's, you have to tie all of those together in the record and really put it in their path and at their fingertips and have had their buy-in as to what the content in it is. It's a lot of work to make it easy. And once you've done the work, then it helps the folks at the front line. And that's kind of why we're here. So I don't know if that helps with it's not just about the score, it's about giving them what they need to see. And part of that is pulling all of it together in that report for them and then giving them something that they can really use to act on what they're finding.
I so appreciate this information. Anybody else have any questions? We have about 3 minutes left, which is not a lot of time. Please unmute yourself if you have something to ask. We'll give you just a couple of seconds here.
Or if you have something to share that your organization is doing something with a predictive tool that, I didn't cover or haven't thought of yet, because that's kind of why we like this whole task force, is that we learn from each other.
So true.
Just saying, we have a lot of smart people.
All right.
Let me say one more time. Thank you for the opportunity. This is a huge passion of mine. I love predictive analytics. I love my doctoral project was on sepsis and the predictive analytics for it. So it's a little close to my heart, and I appreciate the opportunity to share it with you all. So thank you very much for that.
All right. Thank you so much. And, I've written down here sepsis workflow, possible CE. So we'll reach back out and get in touch. So hopefully you got some slides. I think that would be a really interesting talk to give as well to follow up on this one, because we all need to, if we are able, move toward predictive analytics. I think it takes a lot of the workload off of providers and nursing staff, and it does allow them to focus more on what is needed, what's critical in the moment. So thank you very much. All right. We are closing out the CE portion of our meeting. If you are not a member of the DFW Hospital Sepsis Task Force, please log off at this point. If you are in the meeting, you will receive a link to claim your CE. So that should be forthcoming in a couple of days. And we'll give just a minute for everybody to log off that is not part of the task force. And we thank you for coming.